Welcome to the award-winning AUA Leadership and Business Podcast, an official podcast of the American Urological Association.
Welcome to the AUA Leadership and Business Podcast, where urologic professionals experience the practical application of business acumen essential for success in today's dynamic professional landscape. I am Dr. Micheal Darson, and in today's episode, we will discuss the future of advanced payment models in prostate cancer treatment, specifically focusing on bundled payments for prostatectomy. Joining me today for the discussion is Dr. Ruchika Talwar. Dr. Talwar is a urologic oncologist at Vanderbilt University Medical Center and medical director in the Episodes of Care office, where she leads and operationalizes BUMC's specialty value-based care programs. Dr. Talwar has served in several national leadership roles, including the chair of the AUA's Residents and Fellows Committee, the Health Policy, Young Urologic Oncologist, and Women in Urologic Oncology Committees of the SUO, and is currently the fundraising chair for the AUA PAC. She held the H. Logan Holtgrew Legislative Fellowship in 2022, where she spent time working on Capitol Hill in the office of Congressman Darren Soto of Florida. Dr. Talwar, welcome.
Thanks so much, Dr. Darson. It's a pleasure to be here.
That's quite a resume to start out with.
It's really fun when you get to blend what you love with your day-to-day work as a surgeon. So I just like to get creative.
One of the things that caught my eye was the medical director in the Episodes of Care office. Can you expand on that a little bit?
Yeah. It's a role that you don't hear a lot about when you're talking to academic surgeons. So Vanderbilt University Medical Center, like many other academic medical centers across the country and healthcare systems, actually, more broadly speaking, have value-based care arrangements, whether that's with Medicare or private payers like insurance companies. And at Vanderbilt, the subset of our specialty value-based care programs, such as those in surgical subspecialties or things like musculoskeletal areas, those are all within the purview of my office, where I serve as medical director. So that means that I am the clinical set of eyes on all of our value-based care arrangements that touch specialty care. And the fun part of my job at Vanderbilt is we actually have our own homegrown set of commercial bundled payment programs, including a bunch in surgical subspecialties that we market directly to our self-insured employers. So it's a great way to take my day-to-day experiences as a surgeon in a large academic healthcare system and ensure that we're partnering with our local self-insured employers in a way that saves them money while also, making our community healthier.
That sounds like a fascinating position. I know that one of the kind of tugs of war that go on with situations like that are how do you agree on the value-based metrics and things like that. And overseeing multi-specialties, I'm sure that's a unique challenge for you.
Yeah, it is. And the great thing about this program is that it is designed by our clinical experts at Vanderbilt. Every bundle has what we call a clinical lead, and those clinical lead, as well as the chair of the departments, work with my team to help align on meaningful, clinically relevant quality and cost measures. So it really is a nice way to overcome a lot of the hurdles we've seen in Medicare value-based care models, where we may be compared against things that really have nothing to do with our specific practice. So I think part of the takeaway here is that there is a role for specialty surgeons to get involved in advanced payment models and payment reform. And in fact, if we don't, what's going to happen is we're going to be left dealing with Medicare value-based care cost and quality measures that don't really impact the quality of care we give to our patients. So it's pretty fulfilling. Every Monday I'm in clinic, every Thursday I'm in the operating room, and the rest of the days I get to work on this.
Yeah, it sounds like it's very progressive, and hats off to both Vanderbilt and you for taking that role on. It's going to be very interesting to see how that rolls out with time, for sure.
Yeah, absolutely.
One of the first things we wanted to start started talking about was the current state of bundled payments. But, I wanted to maybe have you kind of go over some fundamentals of what bundled payments are and kind of a little bit more of a historical perspective on them before we get to the current state.
Sure. I think it is an area where a lot of urologists don't necessarily feel very comfortable. Whereas if you talk to some of our orthopedic surgery colleagues, they know a lot about bundled payments. So the way that we deliver healthcare traditionally, and what's relevant for most urologists, are that we bill in what's called a fee-for-service manner, which means that we are paid based on the services that we deliver. So if I'm doing more surgery, I'm going to bill more RVUs and I'm going to get paid by payers more. It really is a volume-based system. And bundled payments, instead of focusing on things in a fee-for-service manner, actually bundle an entire episode of care under one cost. We've seen that historically over the past decade, particularly in the surgical subspecialty space in orthopedic surgery, because one of the first bundled payment models to come out of Medicare was the joint replacement model. And data actually showed that in this joint replacement model, where Medicare was paying out one single price for an entire joint replacement episode that started at the day of the joint replacement surgery and lasted a predetermined amount of time after that surgery. So, for example, if a patient has an index surgery, Medicare would pay one price for that surgery and everything that was billed within the 30 days after the surgical date. One price, one bundled payment for post-op care, emergency room visits, readmissions, care for infections, home health, PT, all of those services. I mentioned that urologists haven't really seen that, because historically, other surgical subspecialties such as urology have been somewhat immune from this idea of bundled payments. That's changing, and I think we'll get into that later. So I think it's the perfect time for urologists to pay attention to what's going on and potentially get ahead of what may be mandated by Medicare for us to participate in the future. Now, you might ask, what was the purpose of bundling? Like, why not continue in a fee-for-service way? Well, we know that healthcare expenditures over time continue to rise. It's really unsustainable. And specialty care, particularly surgeries like joint replacements, have been very expensive for Medicare to cover. And data from the joint replacement bundle program that Medicare put out actually showed that not only did costs decrease, so Medicare ended up spending less on joint replacement care, but the quality remained good. People were rewarded based on hitting their quality measures, and the quality of care was not compromised by changing the way that orthopedic surgeons were paid for those services.
So let me ask you a more complicated question. So you're in an orthopedic group. You've got 10 orthopedic surgeons. They're doing their thing. They're very good. But say every once in a while, one of their patients has to go to the ER. How is that payment split? I mean, how does the ER get paid for their involvement in the care?
Yeah, it's a good question. So historically, there's different ways to do it, right? One common way that is often used in these sorts of models is that as the care is delivered, the claims are paid out in a fee-for-service way, right? Like Medicare just continues to pay those claims fee-for-service. For example, that ER visit is paid for. Any imaging associated with potentially a complaint of pain after surgery is paid for. But after the performance year, Medicare will actually go back and reconcile the amount of money that they paid out for all of your fee-for-service claims and compare it to the target price of what the episode should have cost. So if you do a good job and you remain under cost, let's say, although you had that one ER visit, nobody else had an ER visit, and you ended up staying under your target price, Medicare will potentially reward you some extra money for remaining under your target price. Now, let's say a lot of patients had ER visits. And so although Medicare was paying all of these claims fee for service, after the performance year, they go back and they reconcile and they say, hey, we actually overpaid you because we paid for all of those ER visits. So guess what? health system, you owe us money because we actually, all of those ER visits added up and they led to the cost of the care that you delivered being higher than our target benchmark price. And that's a process called reconciliation. Now, I just want to make a comment that you brought up the fact that this was an orthopedic multi-specialty practice, right? And the way some of these bundles worked historically and the way some of the forthcoming models in surgery are going to work is it's really the health system that's getting paid with this bundled payment. Now, the health system has the opportunity to work with that. Let's say they're a private practice orthopedic group. They can potentially participate. That group can participate in the bonus payment scheme and maybe get a little bit of a bonus if they do a good job. So I think there's an opportunity here with the bundling of payments, even to engage private practice groups to be incentivized to care about, why the hospital's getting bundled payments versus traditional fee-for-service payments.
Yeah, that was always that was an interesting experience. I spent close to 20 years in private practice, and our community was getting into that phase, and it was fascinating the discussions and how it was handled. And it's nice that you can still be in private practice and still participate in a healthcare model that's value based and show your metrics to be good. I mean, not everybody has to be in an academic setting, or there's a way to do it for everybody. So. Well, thanks for that. That was a great explanation. So what's the current state of bundled payments?
I think we're in a unique time right now. As we're recording this, it's getting close to the end of the year in 2025, and there's a lot of excitement, some may say, and some may say a lot of anxiety, because Medicare has just announced that effective January 1st, 2026, they are implementing a mandatory surgical bundled payment model. They've selected several areas throughout the United States and mandated that all health systems within that specific zone are mandated to participate in this model, which means whether we choose to or not, Medicare is going to pay only a bundled rate for 5 specific surgical episodes. And those episodes include CABG, coronary artery bypass graft, hip and femur fractures, major bowel operations, joint replacements, and spinal fusions. Now, it's worth mentioning that anything oncology and trauma-based are excluded from those 5 episodes, but that means that every single Medicare beneficiary that is seen in those selected areas will be paid out in a bundled fashion. So you can imagine a lot of health systems are pretty nervous about this. They don't get a say. It's mandated. They are trying to figure out ways to engage their surgeons who have historically sort of been immune from a lot of these value-based care discussions, so that they can end up being successful in this new model.
Yeah, it's interesting. The things that you mentioned, the index cases, they've been collecting data on CABGs since I was in medicine. And I would think that things like hips and joints would be not far behind them as far as being able to collect a lot of data. Where does say a radical prostatectomy fall into that?
Yeah, it's a great question. So radical prostatectomy right now in the Medicare model is not included based on what Medicare has selected in this program. It's called TEAM, the Transforming Episode Accountability Model. But, I think it's a really important time for us to have this conversation as urologists. It's something I've been thinking about a lot as a urologic oncologist. And the reason for that is Medicare is looking more and more closely at cancer care. Now, they have piloted value-based care models for cancer care that is for medical oncology patients. There's been 2 of those, the OCM and the EOM model. The EOM model is the Enhancing Oncology model. That is active right now as we speak. But in my opinion, based on the way I've seen, Medicare head over the past decade or so, straightforward surgical oncology episodes like radical prostatectomy. I'd argue even partial nephrectomy for cancer care, breast cancer surgery. All of those are probably on Medicare's radar to pilot out bundled payments in the future. And the reason for that is it's not, if you look at the type of patients who are undergoing radical prostatectomy, those patients generally only require one surgery for, potential cure. Of course, they may need adjuvant treatments down the line, but if you're looking at perhaps their care for 1 year, if they're going to go the surgery route, really the only care related to that prostate cancer care in most patients is the one surgery. Most people go home the very next day. Some people even might go home the same day. We've seen trends in that. And within 30 days, most people have all of their prostate cancer surgery related care paid out. And so it seems like low hanging fruit for me, particularly for a diagnosis that is quite common, right? It's quite common in men and it's common in Medicare beneficiaries. If you look at men who are on Medicare 65 and over, seems to me like, prostate cancer care certainly shouldn't be far off from what Medicare is targeting. And I think it's also worth mentioning that although it hasn't been a focus for Medicare yet, there are companies out there. There are value-based care startups and value-based care companies that have already partnered with large employer groups who are self-insured to try to improve their prostate cancer surgery-related spend. And so those companies have partnered with practices or with academic medical centers to do just this, to bundle all of the care and provide those health systems who participate with more commercially insured lives by shuffling over volume, and those claims are paid out in a bundled way. So it's not novel; it's already happening in some commercial markets, and I have a feeling Medicare is going to be next.
What we've kind of started talking about this, but what are some of the historical barriers to bundled payments, specifically in urology?
I think part of the challenge in urology has been that it is quite a niche subspecialty, right? I think although there is quite a bit of spend for urologic care, we know bladder cancer, for example, is the most expensive cancer to treat in a person's lifetime. We know that prostate cancer is one of the most common cancers that we see in men. It's been pretty siloed off. Urology doesn't necessarily fall under general surgery. And furthermore, a lot of urologists are not really engaged with Medicare in these sorts of programs. So we haven't seen it been a target yet. And I think some of the other barriers also include the fact that there is an access problem in urology, particularly in rural America. It can be really difficult to get urologic care. We know that there are many, many counties in America that don't even have a urologist based on AUA census data. So I think we haven't seen Medicare really focus on this area as it relates to value-based care yet. But again, as I'm seeing them branch out into more and more surgeries, in parallel, I'm seeing a lot of Medicare's focus on cancer. I think it just makes sense that prostatectomy is going to be a natural next focus if in the next few years.
Yeah, I think of the urologic cancers, that's probably the lowest hanging fruit because, if you try to, I think it would be very difficult to come up with a bundled payment program for like a cystectomy because those patients are usually a lot sicker. If they're getting pre-cystectomy chemo, all that kind of stuff just makes it a lot harder to put a number on that. But prostatectomy is right there. So
I totally agree.
What are the benefits of an advanced payment model in prostate cancer treatment?
Yeah, it's a good question. So if we think about an advanced payment model for prostate cancer outside of just the prostatectomy bundle that I talked about, I also think there's potential for an advanced payment model looking at prostate cancer care in general. And the reason I say that is right now, for the most part, urologists are incentivized to do more right? To treat more, whether that's do more surgery, maybe do more biopsies in some sense. And for people who have financial stake in a radiation treatment center, for example, like some urologists do out in the community, there's a financial incentive that exists there as well. And the nice thing about bundling prostate cancer care in this way is you will get paid for the care of that patient no matter what. Now, if a patient is on active surveillance for prostate cancer, one could argue that as a urologist caring for that patient, you might actually get paid less. You may get paid less to simply do an index biopsy, counsel the patient, check a PSA, get an MRI all over the span of a year, maybe do a second confirmatory biopsy. That all in aggregate might pay less than the care if the patient was going to undergo a radical prostatectomy, because you'd be reimbursed for that procedure. And so if you bundle payments for prostate cancer care, you then inherently create an incentive to put patients on surveillance. Or actually, let me rephrase that. I would say you remove the incentive to overtreat or do surgery for patients who might be appropriate active surveillance candidates. So you're really just realigning the incentives to make more sense with what is best for that specific patient. And so I think there's a big opportunity to improve our uptake of active surveillance care for men with low risk prostate cancer. And beyond that, again, if we look at the healthcare system more broadly, we know that current healthcare expenditures are unsustainable. I mean, we're extrapolating trillions and trillions of dollars of healthcare spend over the next decade. Our economy cannot sustain that. And so moving towards value-based care is a way to improve some of that spend, but allow physicians to maintain their focus on appropriate care, high-level quality care when we're talking about what treatment is best for a patient.
All right, so we'll move along to future directions.
Yeah, I know. Future directions for bundled payments, I think, are really robust. And I just want to put one thing out there. I think a lot of people listening to this podcast might say, wow, this feels really theoretical. We haven't even seen Medicare make movement on prostate cancer care or any urologic care yet. But I just want to highlight the fact that we are seeing multiple companies out there already approach large healthcare systems to partner for bundled payment care in prostate cancer patients in their endeavors with large self-insured employers. So it is happening. It is out there. Just because it's not quite mainstream yet, that doesn't mean it won't potentially be in the future. And I want to stress everyone listening to this podcast, if we don't take an active role in shaping what prostate cancer or urologic bundled payment models could potentially look like in the future, what will happen is Medicare will come up with their own rules, implement them, mandate them. Again, this new model is mandatory. We don't have a say. We are participating in the TEAM program. And then urologists will lose the ability to essentially shape what this looks like in the future. So I think we are really at a pivotal point. I know that my research team has done some work to try to get some literature out there and potentially create a precedent for what these sorts of bundled payment models could look like. And I think it's important that we continue to have these sorts of conversations, continue to engage with our elected representatives who are often thinking about these sorts of larger healthcare related problems, and ensure that we have a say in what these advanced payment models look like in the urology space.
That's a great point. For our residents that are listening, what advice what would you advise them if they want to get involved and they want to become part of this voice?
Yeah, I think that the AUA is really leading the way in its advocacy efforts on making sure that the urologic voice is heard regarding this and other important health policy initiatives. So I would definitely encourage residents, trainees who are interested to learn more about how the AUA's resources can prepare you for these sorts of broader healthcare practice related initiatives. There's obviously the educational content that you all put out through this Leadership and Business podcast. But in addition to that, the AUA, under their policy arm, have several committees that you can join to learn more. So, a lot of this has to do with coding and reimbursement. The AUA has a coding and reimbursement committee. There are several committees related to state advocacy, federal advocacy. And lastly, I'll just mention that, there is the AUA Political Action Committee, the AUA PAC, that supports congressional representatives whose policy stances align with the AUA's. So those are just a few ways to get involved for people who are looking to learn more. Every year, the AUA also hosts their advocacy summit, which is our annual fly-in. You can go there and learn more about some of these important issues. In fact, we discussed this idea of bundled payment for prostatectomy at the AUA summit last year, and it sparked a really robust and interesting conversation. And you can actually chat directly with your congressional representatives about these sorts of issues because during our time on the Hill for the AUA summit, we do meet with our local congressional representatives in their offices. So lots of ways for trainees to learn more. Unfortunately, we don't receive formal education on this in medical school or in residency, but I think that our organization does a great job of trying to get this information out there.
Yeah, I'm glad you brought up the AUA summit. I participated in that for well over a decade, and it was one of the best advocacy things that I feel like I ever did. And, I always tell people when you're talking about advocacy, the first thing they think of is, oh my God, I don't have time to do one more thing. But if there's one thing that I learned is advocacy and the AUA summit actually, I think, decreases burnout, not increases it. So, and I think the advice you gave for the residents also is really good for, the young people that are out of residency now, but, want to get involved because it's their future, right?
Yeah.
So the more involvement, the better. And I think going through the AUA is a great way to get started.
Yeah, absolutely. One more thing I should mention specifically for trainees, there is a policy and advocacy recruitment work group. It's called the PAR. That's under the AUA policy. I think it's under the AUA Public Policy Committee. That's a great way specifically for trainees to meet other like-minded trainees who are thinking about these sorts of problems. And last I heard, that group is almost maybe even 100 strong now. It's a great way to just get to learn more and at least connect with others who are thinking about these sorts of problems.
Well, thank you, Dr. Talwar, for sharing time and expertise with us today.
No problem. It was a pleasure, and thanks for the invitation.
And thank you to our audience for joining us on the AUA Leadership and Business Podcast. Until next time, continue to learn, lead, and excel.
Make AUA Leadership and Business your go-to podcast. Subscribe today by searching Leadership and Business on your favorite podcast app and enhance your leadership and business education needs. Until next time, continue to learn, lead, and excel.